80% um, mortality or a failure of extubation rate, we initially were trying as hard as we can not to intubate these patients. But we needed a trigger. We needed a trigger in order to intubate a patient, and that trigger we had decided arbitrarily, this was very early in our experience, it's still early in our experience, was when they required 80% high flow to achieve a SAT of 88 to 90. Now, anyone who has dealt with these patients is probably highly perplexed about how remarkably they can tolerate a level of hypoxemia that we are not used to. So our patient, this particular patient who was in her 50s with very little medical problems, we went over to discuss intubation, and she had no respiratory distress. She complained of raging fevers, and she felt terrible, as most of them do, but she did not have any respiratory distress, and she refused intubation. She did not feel like she needed it, and for us as a clinician, with staring into the face of a highly intervention that is from everyone else's experience suggests a high mortality, we didn't intubate her, and she asked that we do everything we can to not intubate her and only do it when we absolutely really had to. Now I was an emergency physician for a long time. I've done a critical care fellowship, and I always considered myself to be fairly adept at understanding when someone absolutely requires it, when they're going into respiratory failure. And for the next 2 days, we spent a lot of time with her, proning her on high flow and doing various things. And it was an extremely perplexing process because to determine when she needed it was nothing like anything I've ever seen. And eventually, she got progressively more hypoxemic to the point where she was saturating in the high 60s on max high flow, and we decided that this was absolutely time to do it. And she called her husband. She was able to speak and explain what was going on. And then we intubated her and put her on the vent. Now, everything I have seen, including patients that we did not intubate because they had very, very lots of comorbid conditions and were unlikely to survive, a 10 to 14 day vent run, suggests that there may be a possibility that we are dealing with a disease that we have never seen. And in speaking with doctors around the country, there seems to be something about this clinical syndrome which I personally have never ever seen before. And as opposed to patients that are going into respiratory failure, meaning they are fatiguing their respiratory muscles, which is typical of pneumonia leading to ARDS, influenza leading to ARDS, pancreatitis leading to inflammatory state leading to ARDS. These patients, as far as I can see, do not experience respiratory fatigue. This seems to be a pure hypoxemic failure, which is a very difficult and strange thing as a clinician to be countered with. In general, it seems to me, and this is just my clinical observation, part of the reason I wanted to speak, because I very much look forward to responses and to hear about the experience from everyone, including our Italian colleagues who have a lot more experience than us. But this condition seems to, at least clinically, at least the syndrome, the constellation of symptoms, seems to most mirror that of either decompression pulmonary sickness or high altitude sickness. And when you speak to these patients at the bedside, they simply don't have the overt shortness of breath and respiratory fatigue one would expect with an alveolar condition. That is to say, with a condition whereby their alveoli are either filled up with pus or fluid or some other thing worsening their compliance. So then, if you look at the recent letter written by Gattinoni, obviously everyone knows one of the legends of ARDS. He suggests most recently on March 30th, it was published, I think it was put out on March 27th, that really we're dealing with a high compliance condition in which the people seem to do the best on liberal tidal volumes, a high FiO2, and with the least amount of peat possible. Now, in general, that is 100% opposite of the approach we traditionally take in ARDS. And from what I have seen at the bedside, there seems to be a somewhat temporal correlation between when we intubate them and when they go into multi-organ failure. Now, there's a very valid argument that their disease process is worsening. And so we are intubating them at a very severe state of their disease, and perhaps they would have gone into multi-organ failure anyway. But I would just ask those that are bedside, there seems to be somewhat of an exaggerated, even more than one would expect, in the relationship between when they're put on the vent and when they go hypotensive and when they go into renal failure and eventually get cardiac conditions. And, this refers to sort of one of my fears, which is it possible, is it at all possible that this disease, COVID-19, or you can say the lung aspect of COVID-19, is not inherently linked to acute respiratory distress syndrome? Could it even be possible that what we are seeing may be a complication of the high pressures we are inevitably using with a severely hypoxemic condition in order to obtain saturations that we find adequate? Which is to say, is it possible that in short, we are causing lung injury as we are trying to save these patients? And this is not something I have an answer for, but the findings by Gattinoni and from everything else I'm reading suggest that we need to at least open our minds to the possibility, primarily because that means that the interventions we are using, we may be using in a stage too late, whereby the cytokine response we are seeing may not necessarily be related to the natural course of the disease, but may be related to the course of one of our primary interventions. So I don't have an answer for this, and I hope to get responses, and I hope it will at least inform and stimulate some thoughts away from here. And I really do. I thank you for listening, and thank you for your time.
Dr. Siddell, this is really and insightful observations. I hope this can generate additional thoughts and questions way beyond this session today. I want to thank all our panelists as well as our speakers, and I'm going to take a few questions that came through the chat box. Please feel free to send more questions. Just in case I lose some of you, I just want to remind you this is being recorded.